This video begins with a brief overview of health history taking, followed by the anatomy of the head, examination of the head, skull, hair, scalp, and face, anatomy of the eyes, assessment of visual acuity, examination of the eyes and fundi, anatomy of the ears, inspection and otoscopic examination of the ears, and tests for hearing. We conclude the video with tips on describing your findings. You will see the examiner assess a healthy patient. In clinical practice, you may detect the same normal findings, or you may discover normal variations or abnormal findings. The health history interview is a conversation with a threefold purpose: to establish a trusting and supportive relationship, to gather information, and to offer information. In the case of new patients, you will gather information that will form the basis for a comprehensive written health history. For patients seeking care for a specific complaint, you may prepare a more focused, problem-oriented history. In either case, you'll record the patient's chief complaint along with common or concerning symptoms. Common or concerning symptoms relating to the head, eyes, and ears include headache, change in vision resulting in hyperopia, presbyopia, myopia, or scotomatous, double vision or diplopia, hearing loss, earache or tinnitus, and vertigo. By eliciting the patient's concerns before the examination, you prepare for an examination that is efficient and productive. With the patient's health history in mind, you are now ready for the examination. Before beginning, let's review the important regions and structures of the head. Regions of the head take their names from the underlying bones of the skull. The frontal area overlies the frontal bone, the temporal area the temporal bone, the parietal area the parietal bone, and the occipital area overlies the occipital bone. The superficial temporal artery passes upward just in front of the ear, where it is readily palpable. Two pairs of salivary glands lie near the mandible. The parotid glands lie superficial to and behind the mandible, and become both visible and palpable when enlarged. The submandibular glands are situated beneath the tongue, located deep to the mandible. The openings of the parotid and submandibular ducts are visible within the oral cavity. Now begin your examination with inspection of the head. Observe the size, shape, and position of the skull, as well as its proportion to the neck and the rest of the body. Note any deformities, depressions, or lumps. Inspect the hair, noting its quantity, texture, distribution, and pattern of loss, if any. Part the hair in several areas to inspect the scalp. If the patient is wearing a hairpiece or wig, ask the patient to remove it. Observe the scalp for scaling, lumps, lesions, scars, and lice or their eggs, which are tiny white ovoid granules that adhere to hairs. Palpate the scalp and skull for masses and tenderness. Assess the color and condition of the skin on the face, noting its color, pigmentation, texture, thickness, hair distribution, and any lesions. Look for scars, masses, and edema. When examining the patient's face, observe it at rest and during conversation, noting facial expressions and contours, and observing for asymmetry and involuntary movements. The cornea is the transparent anterior portion of the outer covering of the eye. External structures of the eyes also include the sclera, pupil, upper and lower eyelids, medial and lateral canthi, and eyebrow. Behind the cornea lie the lens and iris. The conjunctiva is a clear mucous membrane consisting of two easily visible components. The bulbar conjunctiva covers most of the anterior eyeball. It adheres loosely to the underlying tissue and meets the cornea at the limbus. The palpebral conjunctiva lines the upper and lower eyelids. A film of tear fluid protects the conjunctiva and cornea from drying and infection. This fluid comes from three sources: the lacrimal gland, which resides within the bony orbit above the eye, the conjunctival glands, and the meibomian glands, which open along the margins of the eyelids. Tear fluid from the lacrimal gland above the eye drains medially through the lacrimal puncta and passes through the lacrimal sac and nasolacrimal ducts into the nose. The fundus is visible through an ophthalmoscope. Fundus refers to the posterior wall of the eye. The retina is the light-sensitive membrane that covers the fundus. A transparent mass of gelatinous material called the vitreous body fills the eyeball and is not usually visible through an ophthalmoscope. The optic disc is the point where the optic nerve enters the retina. About 1.5 millimeters in diameter, the optic disc contains no sensory elements, making it insensitive to light. Most optic discs have a small central depression called the physiologic cup. The cup is lighter than the rest of the disc and less than half the disc's horizontal diameter. The retinal arteries and veins converge at the optic disc. Lateral and slightly inferior to the optic disc lies the fovea, which is the area of central vision. The macula surrounds the fovea but has no visible margins. Note the absence of retinal vessels in much of this area. To examine the fundus, light must pass through the pupil, lens, and vitreous body to reach the optic disc, retina and retinal vessels, macula, and fovea.
Step here, please. I'm going to test your vision.
Begin the eye examination by assessing the patient's visual acuity. Have the patient stand 20 feet from a Snellen eye chart. Patients who use contact lenses or glasses should wear them. However, patients should remove reading glasses because reading glasses blur distance vision. Note the visual acuity printed at the side of the line of the eye chart. Visual acuity is expressed as two numbers, for example 20/20. The first number indicates the distance of the patient from the chart, and the second number indicates the distance at which a normal eye can read that particular line of letters without the aid of corrective lenses.
And read the smallest line from right to left.
Repeat the test on the other eye.
D, Z, P.
Now prepare to test the patient's visual fields.
Now we'll test your visual fields.
For screening purposes, visual fields are tested by
Tell
confrontation.
me when you see my
Face the patient directly and imagine a glass bowl encircling her head.
Look into my eyes with both your eyes.
Ask the patient to look with both eyes into your eyes.
Tell me when you see my fingers.
Then
and
place your
which side
hands
you
about 2 feet apart lateral to the patient's ears.
see. Okay.
Slowly move your wiggling fingers of both hands along the imaginary bowl until the patient identifies them. Normally, a person sees both sets of fingers at the same time.
Okay. Tell me now when you see my fingers.
Repeat this action in the upper and lower
Now.
temporal quadrants.
Now.
If you think you have found a visual defect, such as loss of vision in the right temporal field,
Good. Tell me when you see.
slowly move your wiggling fingers from the defective area of the field toward the better vision.
Now.
Repeat this at several levels until you can define the border of the defect.
Now.
Then test the other eye for an accompanying defect.
Now.
Now the other side. Look directly into my eyes.
Next, visually inspect the patient's eyes. Observe for alignment and symmetry. Also examine the eyebrows and closely inspect the eyelids. Normally, the upper eyelid covers a portion of the iris, but does not overlap the pupil. Inspect the area over the lacrimal gland and lacrimal sac for swelling. To inspect the sclera, the bulbar conjunctiva, and the palpebral conjunctiva of the lower lid, ask the patient to look up as you depress the lower lids with your thumbs. Normally, the bulbar conjunctiva is transparent, with vessels running through it, and the underlying sclera is white.
Good.
To see the palpebral conjunctiva of the upper eyelid, the eyelid must be everted. The palpebral conjunctiva is pink and uncongested. Carefully inspect each iris and pupil. Normally, iris markings are clearly defined, and the pupils are round and equal in size. With oblique lighting, inspect each cornea and lens for opacities. To do this, shine a penlight from the side toward the eye. You should see no opacities. Next, test the pupillary reactions to light. First, darken the room. Then ask the patient to look into the distance.
Look off in the distance.
Shine a bright light obliquely into each pupil in turn. The oblique lighting and the distant gaze both help to prevent a near reaction. Look for the direct reaction, consisting of pupillary constriction in the eye being illuminated directly. Then look for the consensual reaction, which is pupillary constriction in the opposite eye. Typically, in a darkened examination room, you will need to quickly illuminate the patient's opposite eye in order to provide sufficient light for direct observation of the patient's consensual reaction. Next, assess ocular alignment arising from the extraocular muscles. From about 2 feet directly in front of the patient, shine a light onto the patient's eyes and ask the patient to look at it.
Look at this light, please.
Inspect the reflections in the corneas. They should be visible slightly nasal to the center of the pupils. Next, assess the extraocular movements, looking for the normal conjugate movements of the eyes in each direction, or any deviation from normal. Nystagmus, lid lag, and convergence.
Now we'll test your extraocular
You will check
muscle.
the extraocular movements in the 6 cardinal directions of gaze.
Follow my finger.
These directions correspond to the coordinated action of 6 muscles involved in eye movement innervated by cranial nerves 3, 4, and 6. Stand 2 to 3 feet in front of the patient. Ask her to follow your finger or a pencil as you make a wide H in the air.
Now I'll test nystagmus.
Look for the jerky movements of nystagmus on lateral gaze and on upward gaze. A few beats of nystagmus on extreme lateral gaze are normal. In a patient with lid lag, seen in hyperthyroidism, watch for a rim of sclera between the upper lid and iris as the eyes move up and down. These movements should be symmetrical and conjugate. Test for convergence of the eyes by asking the patient to look at your finger as you move it toward the bridge of the nose.
Now follow my finger.
Eyes can usually follow your finger to within 5 to 8 centimeters of contact. Next, after darkening the room, conduct your ophthalmoscopic examination. Switch on the ophthalmoscope light and adjust it to the large, round beam of white light. Also, make sure the light is set to the appropriate brightness. Set the ophthalmoscope to the 0 diopter. Ask the patient to look over your shoulder at a specific spot on the wall.
Now look straight ahead at the dot on the back wall.
Remember to use your right eye and right hand as you examine the patient's right eye. From 15 inches away and 15 degrees lateral to the patient's line of vision, shine the light beam on the pupil. Placing the thumb of your other hand over the patient's eyebrow may steady your approach and allow closer examination. Locate the red reflex, which should appear as an orange glow in the pupil. Note any opacities that interrupt the red reflex. While holding the red reflex in view, approach the patient's eye along a 15-degree line lateral to her line of vision until the ophthalmoscope is close to the eye. Try to find the optic disc by following the retinal vessels centrally toward the place where they converge. Now, using your index finger, bring the optic disc into sharp focus by adjusting the diopter of the ophthalmoscope. Note the color of the optic disc, the clarity of its margin, and the size of the physiologic cup. Normally the disc is yellowish-orange to creamy pink and round or oval with well-demarcated margins. It may be surrounded by white or pigmented rings or crescents. The optic cup-to-disc ratio is usually less than 1:2. Adjusting the angle of your head and instrument and moving them as a unit, inspect the retinal vessels and adjacent retina by following the vessels from the disc to the periphery in 4 directions. Note the relative size and color of the narrower, lighter arteries and the larger, darker veins. Look for changes, such as nicking of the veins at arteriovenous crossings. There should be none. Examine the surrounding retina for hemorrhages or exudates, noting their size, shape, color, and distribution. Again, there should be none. Finally, examine the fovea and surrounding macula by directing your light beam laterally or asking the patient to look directly into the light. The tiny, bright reflection at the center of the fovea may help orient you. To focus on more anterior structures, such as opacities in the vitreous body or the lens, change the diopter on the ophthalmoscope to more positive numbers, such as +10 or +12. Repeat the ophthalmoscopic examination on the patient's left eye using your left hand and left eye. The ear is composed of 3 compartments: the external ear, the middle ear, and the inner ear. The external ear includes the auricle and the ear canal. The ear canal opens behind the tragus and curves inward until it reaches the tympanic membrane, or eardrum, an oblique membrane which marks the lateral limit of the middle ear. The middle ear is an air-filled cavity that transmits sound by way of the eardrum, and 3 tiny bones or ossicles, the malleus, the incus, and the stapes. The malleus holds the eardrum inward at its center. The 2 chief landmarks of the malleus are the handle and the short process. From the umbo, where the eardrum meets the tip of the malleus, a light reflection called the cone of light fans downward and anteriorly. Above the short process lies a small portion of the eardrum called the pars flaccida. The remainder of the eardrum is the pars tensa. The middle ear connects to the nasopharynx via the eustachian tube. The inner ear contains the cochlea, cochlear nerve, and other structures that are inaccessible to direct examination, but which may be assessed by testing auditory function. Begin the examination of the ear by inspecting the auricle for position, size, and symmetry. Also inspect the opening of the ear canal for discharge, swelling, redness, lumps, or lesions. If the patient has complained of ear pain, or if you see signs of inflammation, check for tenderness by moving the auricle up and down and pressing firmly on the tragus. Pain on these maneuvers suggests inflammation of the ear canal. Also press firmly on the mastoid bone behind the ear. Tenderness here suggests middle ear infection. Next, examine the ear canal and eardrum using an otoscope. To do this, select the largest speculum the patient's ear canal will accommodate. Position the patient's head so you can see through the otoscope comfortably. Grasp the auricle firmly but gently and in an adult, pull it up, back, and slightly out to straighten the ear canal. Brace your hand against the patient's face and hold the otoscope between your thumb and fingers. Then insert the speculum gently into the ear canal. Note any cerumen or earwax that may impair your view. Also observe for any discharge, foreign bodies, redness, swelling, or scaling. There should be none. Slide the speculum slightly down and forward and maneuver it until you can see as much of the eardrum as possible, including the pars flaccida and margins of the pars tensa. Note the color and contour of the eardrum with its distinct cone of light. Normally, the drum is pearly gray. Also, note the position of the handle of the malleus and inspect the short process of the malleus. The handle of the malleus, with the umbo at its tip, crosses the eardrum obliquely from the cone of light upward toward the short process. Be sure to examine the other ear in the same manner.
Now I'm going to test your hearing.
To assess hearing, test one ear at a time. Occlude one of the patient's ears with your finger. Stand 1 to 2 feet away from the patient. Exhale fully to minimize the intensity of your voice. And test the open ear by softly whispering numbers or words that contain equally accented syllables, such as 99 or baseball. Gradually increase your volume until the patient can identify your words. Repeat on the other side. During the test, be sure to conceal your mouth to prevent lip reading.
21.
21.
If hearing is diminished, test for lateralization by performing the Weber test. To do this, place the base of a vibrating tuning fork firmly on top of the patient's head. Then ask if the sound is louder in one ear or the same in both ears.
Good.
Normally, the sound is heard in the midline or equally on both sides.
Tell me when the sound stops.
Next, compare air and bone conduction by performing the Rinne test. Place a lightly vibrating tuning fork on the mastoid bone behind the ear.
And again?
When the patient indicates that the sound is no longer heard, quickly place the vibrating fork near the ear canal.
Now.
Normally, the patient can hear the sound longer through air than through bone.
Tell me when the sound stops.
Be sure to test the opposite ear. A clear, well-organized clinical record, employing language that is neutral, professional, and succinct, is one of the most important adjuncts to patient care. For a healthy patient, your write-up might include language such as head, skull normocephalic and atraumatic, hair with average texture, eyes, visual acuity 20/20 bilaterally, sclera white, conjunctiva pink, pupils constrict 4 mm to 2 mm, equally round and reactive to light and accommodation, disc margin sharp, no hemorrhages or exudates. Ears, acuity good to whispered voice, tympanic membranes with good cone of light, Weber midline, AC greater than BC. To summarize, examination of the head, eyes, and ears includes examination of the head, skull, hair, scalp, and face, assessment of visual acuity, examination of the eyes and fundi, inspection and otoscopic examination of the ears, and tests for hearing.